Good evening, everyone. Today's topic of discussion is going to be on laser photocoagulation in difficult situations. So I'll be talking briefly about the introduction. I'll go about how the laser mechanism works, what are the types of lasers that are available in day-to-day practice, and what are all the difficult situations that we face routinely during our OPD lasers, as well as we'll touch a little bit upon difficulties in laser during surgery as well. So moving on to the introduction, the medicinal use of laser was discovered by Mayer Schwickerath in the year 1950. The first xenon arc coagulator was introduced by Schwickerath and Littmann by Littmann in the year 1956. It was in combination with Zeiss. Esperance in the year 1968, he introduced the argon laser. So few other lasers came in the late 90s, like the pulsed ruby laser and krypton laser, but these lasers are not used nowadays in view of poor safety profile. The most commonly used lasers are the argon laser and the Nd:YAG and our diode laser. So the one on the picture is the xenon arc coagulator, which was introduced by Mayer and Littmann. So how this photocoagulation works? So the lasers of varying wavelength, they produce energy from a strong light source. So these energy, when they are targeted over the retinal tissues, they are absorbed by the retinal pigment epithelial cells, especially the melanin pigment and pigment underneath. So this absorbed energy causes coagulative necrosis over the involved tissue, leading to denaturation of the cellular proteins. So this denaturation leads to the formation of a scar later on. So may I know from the PGs, like what are the different wavelengths of these lasers that I have mentioned? So what is the wavelength of Nd:YAG?
Around 1145.
Not really. Can someone else try? So it's what laser do we use? So is it just the Nd:YAG or it's the double frequency Nd:YAG? It's a frequency doubled.
Double frequency.
Yeah. So what is the wavelength? Can someone else help them? Any of the fellows?
He's asking the frequency of the laser.
Yeah, the wavelength.
Frequency doubled is 532 nanometers.
Yeah, correct. That's right. What about the diode?
810.
Yeah, 810. That's right. So argon has got both the blue and green the green and the red. So it's ranges somewhere between 488 to 510 nanometers. So
just hold on, go back. Can you tell me why it is absorbed by the RP laser?
Melanin pigments are there, so it absorbed by pigment.
So the light is absorbed by whatever is pigmented, right?
Yes,
so retina is non-pigmented. The first pigmented structure is encountered is the RP, so
yes,
that absorbs the light energy.
Yeah, thank you.
Go ahead.
So what are the common indications that we routinely encounter in our retina setting is that the most commonly encountered is the PRP laser, the pan-retinal photocoagulation that we routinely do for proliferative diabetic retinopathies. And of course, those are indicated in neovascular glaucoma and CRVO in the presence of active neovascularization. So this is a patient with PDR, and below is the one with NVG. You can see the new blood vessels, neovascularization of the iris over here. So of course we also do barrage laser to most of these treatable lesions, especially the horseshoe tears, the one with lattices, and here we can see in the first picture there is a retinal break. So we also do lasers to the retinal holes if needed. Okay, let's not go into the details. I'm just giving a brief idea of what all we do. Of course, we do focal lasers in patients with chronic or recurrent CSCR in the presence of focal leaks. We do focal to microaneurysms in presence of non-center involving DMV with succinate retinopathy. And of course, in cases with polypoidal choroidal vasculopathy and RAP lesions, we do prefer focal laser. Yeah, in certain conditions. Okay. So what are the other indications? Of course, this is the fairy looking eye. This is the AROP. We routinely do laser for such conditions, of course in staged ROP as well. We also do sectoral laser for patients with retinal vascular occlusion sequelae and of course FFA guided laser to CNP areas and neovascularization in vasculitis sequelae. So this is a patient with vasculitic BR vivo. And miscellaneous conditions includes your exudative retinopathies in the form of FEVR and coats with neovascularization. This is a patient with FEVR. This is a patient with FEVR and coats. Yeah, it is showing there was a peripheral neovascularization in this case who underwent laser. And of course, we do lasers in patients with retinoblastoma, especially the small to medium-sized tumors. And we prefer to do transpupillary thermotherapy, which is also a kind of photocoagulation mechanism, but on a little more, we make use of the thermal burns. We increase the temperature, basically. Works on the principle of increasing the, damaging, you create a coagulation based on thermal energy. So we also do laser in certain miscellaneous conditions like coloboma with ICM detachments, not always, especially in particular like selected cases if the patient is one-eyed or if the patient cannot follow up in such cases. And of course, we also do a delimiting laser in patients with optic disc with maculopathies. Okay. So these are the main things. So before starting a laser, one must always confirm the demographic details of the patient, especially the patient's age, confirm his name, must confirm the eye which has to be lasered, and proper consent has to be obtained. So if the patient is a minor, definitely get consent from the parents and the surrogates if wherever required, and examine the patient completely. Thoroughly examine the eye before starting any laser to look for any discrepancies between the last finding and the current finding. And of course, please jot down if there is any subsequent injection or laser if planned for the patient. So these are some of the general instructions that has to be kept in mind while advising laser, especially in patients who have active vitreous hemorrhage, or if the patient is having a full-blown like HST, who have the tendency to develop retinal detachment, especially to ask them to avoid sneezing, coughing, lifting heavy weights, and avoid jerky movements. So basically, why we advise these things is basically to control or reduce the valsalva related transmission of the venous pressure into the eye. And of course, in the presence of vitreous hemorrhage, we also ask the patient to sleep, give a propped up position by giving pillows over the head while sleeping. So these are the post-laser drugs that we routinely prescribe to patients. So topical low-potent steroids, loteprednol 0.5% is the one that we prescribe regularly to most of the patients. Especially if we are planning to increase the duration of the topical steroids, kindly follow a tapering dose. Definitely, if there is a pain, go for painkillers, but just make sure that the patient doesn't have any systemic or any allergy history before you giving any potent painkillers like combiflamide. And definitely, if the patient is having any IOP spikes that have been observed post laser, can give acetazolamide or consult the glaucoma clinic and start them on topical anti glaucoma medications as well. And in post-surgery eyes, definitely mostly these patients will be on Predford. One can advise the patient to continue the same whenever possible. And these are move on to the main topic of today. So laser in difficult situations. These are the most commonly encountered difficult situations that we routinely come across in our OPD. Most common thing is the poorly dilating pupil, especially laser and media haze, extreme peripheral lesions where we couldn't, where our laser burns could not reach, and small palpebral fissures and other miscellaneous conditions. So most of the conditions that have been mentioned here can be managed, may be managed with topical anesthesia, but in extreme situations like this, like if the patient is uncooperative, the patient is a child, and the patient is having extreme gaze palsies, nystagmus, or extremes of photophobia, in such cases, one may even consider, you can definitely try the patient, you can try under topical anesthesia, and if the patient, if it's not possible, then it's better to go for laser under sedation or general anesthesia. So moving on to the poorly dilating pupils. So there are n number of causes for patients to have poor dilatation. So first things first, always check whether the pupil is dilated properly, as if the medicine has been, the pharmacological dilatation drops has been put or not. That is the most important thing to consider for a patient who visits our OPD, our laser clinic. That is the most common cause of poorly dilating pupil. Of course, we do have patients with iris coloboma, Marfan syndrome, and patients with retropupillary membranes and ICE with retrocorneal membranes whose pupils don't dilate regularly. Can someone tell me why patients with Marfan's can't, they do have a poor dilatation of pupils? Yeah, excellent. Yeah, that's the answer. So these patients will have basically the sphincter, okay, the patient's muscles, the iris muscles are not properly developed. Yeah. And of course, we have a number of causes for acquired causes of patients having poor dilatation of pupils. Of course, drug induced, especially your alpha 1 agonists like your tamsulosin, all those category drugs should, in those cases, definitely will have difficulty in dilatation of pupils. If the patient is having an ACIOL or iris fixated IOL, again, will be having some difficulty. Patient's pupils won't dilate properly. Then definitely in conditions like PEX and neovascular glaucoma, one must, the pupil won't be dilating completely. So this is a patient with PEX. Here you can see there is the, deposition of the pseudo exfoliative material over the lens, forming that the sign. Can anyone tell me the sign of this? So how do we manage poorly dilating pupils? First things I have already told you, one must definitely check if the pupil is dilated adequately or not. If not, try to dilate with pharmacological agents. If patient is not getting dilated with our routine T, one may even try T plus after checking, ruling out any systemic hypertension. We can even try other agents like homide or yeah. And definitely in case of poorly dilating pupil, one can try to adjust the IDO settings, try to use the smaller size slit and try to adjust the prisms as well. Okay, so trying to do both of these, one might end up seeing the retina better than what we used to see. And in case of posterior pole laser, we can try using the IDO. If it's really not possible, we can even try using slit-arm for posterior pole laser. If still not possible, then one may consider taking up the patient for cryotherapy. Especially in peripheral lesions, we can, if you are not able to connect the laser to the ora, you can go for cryotherapy under local anesthesia. Now, moving on to the media haze. So media haze can be due to multiple reasons. So starting from your cornea, starting from your to your dense cataract and vitreous hemorrhage. So in case of dense cataract and vitreous, in the presence of a PCO haze, one can try laser at a higher power, but try not to increase the duration of the laser, because increasing the duration of the laser, patient might end up having pain, and there is high chance of patient developing choroidal detachment. So try as much as possible to increase only the power. As we have already discussed in few previous classes, we can maximum increase to around 350, maximum 400, but not to go more than that. It's not really safe for the patient. If the laser is not possible at all, then one may plan laser after the cataract surgery. And if there is a very dense PCO haze, one may plan laser after YAG gaps. In the presence of a dense vitreous heme, it is better to do laser in the periphery of the retina by gently depressing the sclera. Once you depress the sclera and try to disperse the vit heme, we might be able to see the retina and try to put few burns over it. Try to do as much as possible by this technique. And in subsequent visits, maybe once the vitreous hemorrhage comes down, we can plan further laser in subsequent visits. If it's really not possible, then we can take up for surgery in such cases. So this is an important thing. So this is what we come across. These are, so especially when we do laser to the peripheral lesions, when these lesions are especially located in the horizontal meridian, when we try to depress, patients are going to have extreme pain. In such cases, one might give some adequate time in between the lasers, give little bit of spacing out. Then if the ora is still not reachable, one may try using different size. So this is a Sheepens depressor. So there are different varieties. This is the one which we usually get in our ARG2. So ARG1 has this kind of. So it's the the width of this Schippen's depressor varies. So it's between 8 to 12 millimeters. What we have got is 8 and 12 millimeters. So in case if you are not able to depress with the 8 millimeter Schippen's, one may try with the bigger one. Sometimes this helps. We might be able to reach the aura with this technique. We can also use a cotton swab to depress the periphery to reach the aura. This is also an alternate technique that routinely we people do. If still you are not able to reach the aura, then you can plan cryotherapy under general or local anesthesia to connect the existing laser marks to the aura serrata. So this is a case seen by Sir VJP sir. So this is a 6-year-old male patient who came to us with a firecracker injury recently to the right eye. Initially, the patient had a high IOP spikes. His lens was little subluxated. He had a dispersed vitreous hemorrhage and a commotio retinae over the posterior pole. Here you can see some of the. So upon subsequent visits, once the vitreous hemorrhage settled, we could localize a small retinal dialysis in the inferonasal quadrant along with an RP atrophy. So this patient was, since he was a child, the patient was taken up for barrage laser under general anesthesia. So since the edge of the laser could not be connected to the aura, the patient had undergone a cryotherapy to the edges so that the laser marks are connected to the aura serrata. How to go about in eyes with deep-seated eyes with small palpebral fissure? One may definitely try without using the speculum initially. If the laser is really not possible, one may try using an adult speculum or pediatric speculum based on the age of the patient. And just remember that whenever you are going for the speculum usage, one must always prescribe topical antibiotics post-procedure along with topical steroids whenever needed. So how to go about treating a post-surgery eye or treating a fellow eye in post-op period? So one must take precautions, aseptic precautions to perform laser in such eyes. So avoid scleral depression. Maximum try to avoid it. In case of non-avoidable circumstances, one can use a sterile cotton swab very gently for depressing the sclera. Always give an antibiotic post-operatively, topically. And when treating the fellow eye, always try to use a shield to cover the operated eye. So this is an important thing. So this is a patient who had undergone post-filtration, glaucoma filtration surgery. He also had an eye condition within the eye which required laser. So a PRP basically. So in this case, so how to go about in such cases? Maximum try to avoid contact procedures, especially try to avoid slit lamp lasers, so that you can skip the contact lens usage. Definitely use sterile precautions to laser such eyes, and try avoiding the superior part. Especially try to avoid depression generally. If still not possible, one may try to avoid scleral depression, especially over the superior quadrant where the bleb or the valve is placed. And if the patient is like if there is so much of media haze, or one may if you cannot depress the sclera, we might even plan the laser once the healing process has occurred after proper glaucoma clinic clearance. So how to go about laser in NVG eyes? Definitely with this amount of corneal edema, so we have to increase the laser power and then only attempt the laser. Yes, we can try to attempt laser in such conditions to the extent possible. If adequate laser burns are not achieved, one may inform the treating consultant, and then we can plan for an anterior retinal cryopexy. So this is a second case. So this patient is a 55-year-old male who is a known diabetic and hypertensive. He came to us with the diminution of vision in both eyes for the past 6 months. Vision was 6 and 6 in both the eyes with a normal pressure. Upon clinical examination, he was found to have proliferative diabetic retinopathy. Upon careful examination, we could make out very early NVEs that were located in both the eyes. So this patient underwent panretinal photocoagulation in 3 settings. So what happened is, after the second sitting, this patient developed multiple serous choroidal detachment in most of the quadrants. So what is the main reason? Reason being the dense laser burns. Here you can see it over here. Especially in the temporal quadrant. How did we manage this patient? We deferred further. Before that, what is the mechanism of choroidal detachment in such condition is? So the main hypothesis is due to change in the fluid dynamics that occurs post laser burns. So high intensity laser burns can cause disruption of the choriocapillaries, thereby leading to transudation of the fluid, and along with the inflammation induced by the laser leads to this serous choroidal detachment. So how did we manage this patient? We deferred further laser, and we increased the dosage of the topical steroids. Then we planned this patient for laser once the choroidals settle after 5 to 7 days, but the patient unfortunately did not follow up with this. So how can we prevent this occurrence? One thing is limiting the number of laser applications. At least 1200 burns is the safest cutoff that has been described in literature. 1500, it's better. 1200, somewhere between 1200 to 1500. Try to space out the laser, and try not to complete in a single setting. That is the most important thing. Avoid putting heavy burns. Okay, and try to put low burn intensity while applying laser burns. And whenever you suspect, if the patient is requiring more number of burns in a single setting, try to increase the steroid in that same setting so that the inflammation induced by the laser can be counteracted by this topical steroids. And of course, whenever we are going for an aggressive kind of treatment, it's better to follow up these patients on a little closer watch. Moving on to our case 3. This is a 35-year-old male patient. He's a one-eyed. The other eye, he's having this diminution of vision in the other eye since childbirth. He had this diminution of vision he came to us with diminution of vision in the left eye since 9 months only. Of course, his vision was 6/9 in that eye, but he was diagnosed with left eye coloboma involving abutting the fovea in the left eye. He was taken up for a barrage laser from elsewhere, followed by which the patient developed loss of vision. So here we can see that the laser burns are put on the nasal side. Here we can also see that the foveal burns are involving the fovea, which is evident on the second image better. So this is the reason for his drop in vision. His vision currently is 6/18 and N6. Luckily his near vision was okay. So how do we avoid such complications? One thing is proper planning of the laser. Try to locate the fovea prior to any laser. It's better to use a slit lamp laser whenever you are trying to perform any laser burns over the macular area. So it's better. And try to laser along the edge of the coloboma rather than going away from it, so that you can try to avoid hitting the fovea. Especially these patients, since they have low vision since birth, most of them will have any nystagmus. So in such cases, sometimes using a contact lens and then going for a slit lamp laser is of great help. And if the patient is still uncooperative for a topical laser, one may plan laser under sedation or general anesthesia. Moving on to the exudative retinal detachment post-laser. So this is most commonly seen especially in patients who have undergone extensive laser. So some of the studies say that the incidence of exudative retinal detachment post-laser is 4%, and this 4% is more common in ROP children, where we put in little more, like we do an intensive laser in such patients. Hence the incidence of exudative detachment is more in such patients. So the mechanism of exudative detachment is similar to that of your choroidal detachment, as I already explained. Management is going to be again conservative unless the patient has developed a rhegmatogenous plaque. And definitely the management is going to be to defer the laser until the exudative detachment settles further, and one might even give some topical steroids for lowering the inflammatory sequelae. Moving on to difficulty in surgical lasers. So before moving on to the endo laser, so we'll just briefly discuss about the types of endo laser probes. So we have got the straight laser probe and we have got the curved laser probe. Can anyone of the fellow tell me like where to use which? Phakic, which is better? Curved is better. Any other indication? Where do we use straight then? Yeah, exactly. So that's the general norm. So the posterior pole laser we can do with your straight probe, and for the curved, the purpose of the curved probe is to avoid touching the phakic lens, especially in phakic patients, young patients. We must try to avoid touching the lens. So using a curved probe may help in avoiding such complications. So especially when you are going more anteriorly, it's better to use a curved than a straight probe. So moving on to the preoperative assessment, how to avoid this difficulty in endo laser. First thing is one must always examine the patient properly. Look for the corneal clarity. Always document if there is any localized corneal decompensation, or if the patient is diabetic or not, because most of these patients they tend to develop corneal edema more easily, because and we cannot always debride corneal epithelium, especially if the patient is having high sugars, then wound healing will become a great problem. So and always examine the anterior chamber details. Look for any pre-existing fibrin or any of the any abnormalities, if there is any new vascularization of the iris, so that we can we can expect preoperatively, like intraoperatively, like if there is a new vascularization, one may try to avoid meddling with the iris, so that we can prevent postoperative or intraoperative hyphema. And always examine the patient, look for adequate, if the pupil is dilating properly or not preoperatively. If the pupil is not dilating preoperatively, then one might expect the use of iris hooks intraoperatively, or other mechanisms like expanders, pupillary expanders intraoperatively. And definitely the lens status of the patient, especially the grade of cataract. If the grade is more, one might plan VR surgery along with cataract surgery. And in case of pseudophakic, always examine the type of the IOL and the position of the IOL. If it's well centered, subluxated, if there is any posterior capsular rupture or not. All these things are gonna make a huge impact on your intraoperative visualization of the retina. And definitely the status of the PC, as I already told, whether there is presence of posterior capsular opacification or not. All these are to be documented preoperatively. So what is the main reason for your poor visualization is the fogging. So what is the main reason being the temperature difference between the lens and the room temperature. How do we go about avoiding this problem? One thing is proper draping. Make sure that the drape is adequate and it is not cut too much on the nasal side of near the nasal bridge. And if it is extended too much, then one may place a tape over the nasal bridge before starting the case only. And once the patient starts having this fogging problem, once the lens starts getting fogged, try to adjust the objective of the lens. Try to move it away from the cornea. And one can place a small saline-soaked gauze over the nasal bridge. That might help in certain conditions. And definitely ask the assistant to turn off the heater. Before starting the case, definitely make sure that machine is primed properly, if the cutter is working properly, and definitely check the illumination of the light pipe. It's very important, because once we start doing the laser and if the illumination goes, then it's going to be a problem. And maintain good ergonomics in most of the cases. So as I already told, good focusing is very, very important to maintain a proper visualization of the laser and of course the surgery as well. Keep coating the cornea with viscoelastic, dispersive viscoelastic, and keep wetting the cornea with saline in between. One might, in case if the laser probe is not functioning, or if there is some disturbance in the aiming beam, one might try to clean the tip of the laser probe. That might sometimes the blood or the fibrin within the vitreous cavity might get stuck to this laser probe. That might cause this disturbance of the aiming beam. So cleaning the tip frequently helps to visualize the aiming beam better. So what are the other tips to improve visualization? In spite of all these, if there is a poor visualization, look for the cornea. Sometimes the cornea might become steamy. Just try to rub the surface of the cornea with the cotton bud gently. Try to make the surface of the cornea uniform. Try to apply viscoelastic and try to reassess the vitreous cavity. If the visualization has improved, well and good. If still it's hazy, one might plan for a epithelial debridement. And before epithelial debridement, one must always make sure that only the center part of the cornea should be debrided. So this is a surgical video. This case was operated by PV sir. As you can see that the view was getting hazy. So yes, this is how one can use an hockey stick, or can use a blade attached to the BP handle, and try to gently stroke the cornea from outside to in. Care should be taken not to touch the limbus, because one might end up damaging the limbal epithelial stem cells. Once the adequate amount of epithelium has been debrided, just coat the cornea with viscoelastic, add some drops of saline, and there you go. The visualization has improved. So always make sure that once you have gone for the debridement, make sure that the patient gets adequate lubricants, and if possible, and if required, topical antibiotics. So definitely this is the cornea part. Moving on to the anterior chamber, if the patient is having if we are having difficulty in visualization in case of fibrin in anterior chamber or due to hyphema, one might always perform an AC wash and then proceed. Yes, if you think that the cornea is already decompensated preoperatively, one might always ask for a cornea backup prior in hand. So this is a patient with an iris claw lens. Here we definitely know that the pupil is not going to get dilated. So in such case, one might definitely go for an iris hooks, or one might use a pupillary expanders like BX. So how to go about in patients with cataractous lens and PCO haze? Cataractous lens, as I already told, one might combine with phaco. And if the patient is having a preoperative subluxated lens or a dislocated lens, one might consider subluxated intraocular lens. One might consider repositioning it before proceeding with the vitrectomy, or in case of extreme dislocation, or if the IOL is completely opacified, one might even consider going for an IOL explantation. So in case of a posterior capsular opacification where the media haze is expected, one might make a small opening using a cutter with a low cut rate. Here this is a patient who had the thick PCO haze. Since the cutter was not able to cut the membrane, capsule was cut using a forceps intraocular scissors, and then the capsule was successfully removed using forceps. Try not to make PC opening more a large PC opening. It's very dangerous because one might end up dropping the IOL and complicating the surgery. And at least 3 millimeters of pupillary opening is more than sufficient for a better visualization of the vitreous cavity. And of course, in laser and phakic eyes, one might always prefer a curved probe instead of the straight probe. And definitely one might avoid crossing over of the instruments. So one periphery to another periphery should not be attempted. Whenever you are trying to do this laser, always keep an eye on the endolight as well, because the endolight might inadvertently touch the phakic lens. So, and if definitely the peripheries cannot be reached using the laser probe, one might try using cryotherapy for such cases. And of course, in aphakic eyes, once we started doing FGE, we might see that the air gets trapped in between the pupillary plane and the anterior posterior surface of the cornea. So in such case, try to gently go inside with the fluid cannula and try to fill the anterior chamber completely with the air bubble. So once you do that, your visualization gets much better. So because once the bubble is single, the you will be able to see the retina better. And definitely this is a general point that in retinal detachment, if the peripheries are not seen and if you have already put a belt buckle, in such case one might complete the laser by just tightening up the belt buckle. By tightening up the belt buckle, you will be able to see the periphery and the aura better. So once you are done with the laser, you can adjust the buccal height accordingly. So especially in pseudophakic eyes, where we end up having this fish-egg kinds of small bubbles sticking over the posterior surface of the eyeball, one might use a flute needle to gently brush up the posterior surface of the intraocular lens to make it uniform. If the visualization is still not good, if there is posterior capsular rupture or something like that, one might use a dispersive viscoelastic to coat the undersurface of the intraocular lens to have a better visualization. So yes, in certain situations where you are planning for a relaxing retinotomy, in such cases, yes, definitely one might use a PFCL, and under the PFCL, once you have settled the retina, you can go ahead and laser such patients, especially if the patient is having very poor visualization. And if the laser sometimes once we have started doing the HFG, if the retina is settled, we have started doing the laser, and after a particular point of time, if the laser is still not possible, if you see that the retina is adequately attached, one might even try to complete the laser after injecting the silicone oil. But this is not done under all circumstances, only in certain circumstances, only when the fluid is completely once the subretinal fluid is completely cleared, we might try this. And to conclude, during OPD lasers, go through the laser list before starting any laser to look for any major discrepancies between your findings and previous day's findings or the previous consultant's findings. In case of any HST or any break that needs urgent treatment, where laser ends could not be connected to the aura, one might do cryotherapy to the laser edges to connect them to the ora serrata, which can be done under OT under general anesthesia or local anesthesia wherever required. In the presence of an intraoperative media haze, meticulous evaluation for the cause of haze and patient management of the same can result in better surgical outcomes. And proper preoperative assessment of the eye for possible causes of poor visualization and small pupil can help in better planning of the surgery. And these are my credits. Thank you.